Of this final module, which is on chronic kidney disease. And today's webinar topic will be discussing the complications of chronic kidney disease. And today's session will be moderated by Dr. Uma Ali ma'am from Mumbai. So before we begin with the webinar, we'll have pre-test, and the link for pre-test I'll be sharing in chat box. So participants, you have time till 7:15 to attempt this quiz. So I'll be sharing the link in chat box. Sneha, you have not made me host. Can you please share that link I've pasted in the chat box?
Recording in progress.
Hello?
Sir, I already pasted in the chat box and I made you the co-host.
Okay. So those of who have joined late, I have shared the link of pre-test in the chat box. I'm sharing it again. Please attempt from there. So good evening once again. Since it's already 16 minutes past 7 o'clock, we would begin the webinar. So to begin the proceeding, now I'll hand over to Dr. Omali ma'am for moderation of today's session. Ma'am, over to you.
Yeah, thank you. Welcome to all the delegates who are attending this webinar. I think many of you all have attended the last webinar, which was the first session on the CKD module. Today we are moving on to the second session. You all learned about epidemiology, etiology, and an overview of evaluation last time. Today we'll be moving on to a very important section of the evaluation. Evaluation of CKD begins with estimation of your GFR and stage of CKD, evaluation for etiology, and a very important part is evaluation of the complications of CKD, because the metabolic and hormonal derangements impact almost every other organ of the body, and it's important to recognize it, evaluate it, and treat it adequately, which has a major impact on both the mortality and the morbidity. To do justice to this vast talk, we have two good speakers. Dr. Sukanya Govindan, faculty pediatric nephrologist from Mehta Children's Hospital, Chennai, who will take us through the complications, followed by a discussion of a case-based scenario by Dr. Hamsa Reddy, faculty from Ramaya Medical College, Bangalore. I welcome Dr. Sukanya to take over the proceedings.
Thank you, Dr. Umali, and congrats to the team behind this NEfPRO initiative. It's really benefiting a lot of postgraduate, pediatric postgraduates in detailed, learning of nephrology. I would now share my screen. I hope my screen is visible.
Yeah, it's visible.
Dr. Sukanya, just a bit closer to the screen if possible for a louder voice. Thank you.
Yeah, so in the next few minutes, I'll be speaking about how CKD progresses through its various stages, what are the main complications of CKD, and I'll be discussing a bit more in detail about these 5 complications: renal anemia, mineral bone disorder, metabolic acidosis, cardiovascular disease, and infections. But by no means these are the only complications of CKD. There are multitude of complications that happens with this condition, unfortunately. I'll be briefly mentioning about the pathophysiology and the consequences of these complications, and then take you through the management of these problems. So we define I think it's already been discussed on how you define chronic kidney disease: any kidney damage that is persistent for more than 3 months, whether structural or functional, with or without a decreased GFR, or a decrease in GFR to less than 60 mils per minute for more than 3 months. Is defined as having chronic kidney disease. The definition might vary in children who are less than 2 years because their GFR is not yet reaching the adult values. We define them by the table here.
Sukanya, you need to speak a bit louder. Sukanya,
Yes.
sorry, but you need to speak a bit louder. We can't hear you very well.
Okay.
Yeah.
So the GFR in GFR in children who are less than 2 years of age is defined as moderate reduction in GFR or severe reduction in GFR based on the plasma EDTA clearance and the table that is given here. So why a cutoff of GFR of less than 60 mils per minute? So it is documented and well studied in literature that there is increased all-cause mortality below a GFR of 60. It also increases the risk of all the metabolic complications that this condition entails, and also there is an increased risk of cardiovascular disease. There is also an increased risk of drug dosing errors, and that's where this figure of 60 ml comes from. So when you're speaking about kidney damage, and that is something that is quite reversible, but when this stage reaches to the stage of decreased GFR, where there is no longer a reversibility, we tend to encounter a lot of complications, and what is left to manage is to assess these complications, try to catch them early and treat these complications and prepare for eventual kidney replacement therapy. The final common pathway in any renal disease is the loss of nephrons, and there is eventually there is a decrease in the nephron number, which results in an increase in single nephron GFR of the remaining nephrons, and there is an adaptive hyperfiltration at the glomerular level. So this includes an increase in glomerular permeability, and this hyperfiltration is also due to an increase in the renin-angiotensin-aldosterone activation. So both of these result in protein leakage and inflammation and remodeling of the renal parenchyma, which ultimately leads to tubulointerstitial fibrosis and secondary FSGS, resulting in decreased GFR, oliguria, and other complications. So on the cartoon here, if you see, there are a GFR of 120 ml per minute after losing the renal functional reserve already means that less than 120 ml already means almost close to 50% of the nephron mass is lost. And when it comes down to almost 60, you lose more the nephron numbers, and almost close to 25 to 30% of your nephron mass is low. And changes happening in the renal parenchyma and loss of kidney function results in all the complications that we see in chronic kidney disease. The kidney not only functions as an excretory organ, but also has a lot of endocrine and exocrine functions. And the endocrine functions are the secretion of renin by the juxtaglomerular cells, which happens in response to a drop in afferent arteriolar pressure, and also increased chloride, which is sensed by the apparatus called macula densa within the juxtaglomerular apparatus. The other hormone that is produced by the kidney is the erythropoietin, which is secreted by the pericytes or the modified cortical fibroblasts. Also, the enzyme 1-alpha hydroxylase, which hydroxylates the 25-hydroxy vitamin D, is present in the mitochondrial compartment of the proximal tubule cells. So as the kidney damage progresses, as the parenchymal damage ensues, this endocrine function is much affected and results in major complications like renal anemia, hypertension, and mineral bone disorder. Kidney also has an important function in promoting net acid excretion by means of bicarbonate reabsorption and also generation. Plasma osmolality and solute balance is maintained by an interplay of tubular transport, the action of ADH and aldosterone. All these functions are gradually lost, and as the kidney failure progresses from CKD 1 to stage 4 and 5, complications like hypertension, anemia, bone disease, growth failure, hyperkalemia, all of them ensue. So moving on to in detailed discussion about each of these complications. Renal anemia is one of the major complications that we come across in children with chronic kidney disease, and a hemoglobin decline happens as early as a drop of GFR happens around 58 ml per minute. And as you move across, progress through the stages of CKD, almost 90% of these children will have anemia and require some form of iron therapy and erythropoietin therapy. Renal anemia is a state of erythropoietin deficiency. There is also a degree of erythropoietin resistance in the bone marrow and the tissues. There's absolute and functional iron deficiency. Anemia not only decreases the functional capacity of the child, it also produces increased mortality, increased hospitalizations. It has a significant role in progression of CKD and also increases the risk of cardiovascular outcomes. So erythropoietin is a gene, is produced by the, is a product of this gene on chromosome 7. And it's unique among the hematopoietic factors is that it's produced outside the bone marrow. Prenatally, liver is the primary site of EPO production, but postnatally, only a little bit of EPO is produced by the liver, and the majority of this function is taken up by the peritubular interstitial cells in the peritubular area of the renal cortex. So this erythropoietin acts on the erythroblast stages of the RBC precursors, and it's also influenced by these molecules called the hypoxia-inducible factors, which in the presence of hypoxia translocates into the nucleus and increases EPO transcription. Of importance in the pathophysiology of renal anemia is the HIF and the erythropoietin interaction, and also the hepcidin-iron interaction. So in normal oxygen tension in the kidney tissue, this molecule called the hypoxia-inducible factor is hydroxylated, and this hydroxylation confers it, makes it viable for ubiquitinization, and this protein tagging makes it amenable for degradation in the proteasome. So this molecule is not stable when there is normal or increased oxygen tension in the tissues. But in hypoxia, this hydroxylation does not happen, and the HIF translocates into the nucleus along with this HIF1, HIF beta, and then acts through the hypoxia responsible element on the EPO gene, and there is increased EPO production and erythropoiesis. In CKD, there is diminished oxygen utilization by the renal tissue, which causes an increase in O2 pressure, and so there is increased degradation of the HIF molecule. Also, although there is absolute iron deficiency in CKD due to various causes, even the available iron is not available for effective erythropoiesis. And this is because of the action of a molecule called hepcidin, which is secreted by the liver. In the normal state, iron is absorbed through the diet. It comes through the reticulo. It is also scavenged from the senescent RBCs and through the macrophages, and also from the reticuloendothelial cells, and it's available to the bone marrow for erythropoiesis. But in the presence of chronic inflammation like the state of CKD, and also when there is decreased GFR status where hepcidin concentration is higher in the blood, this acts on this molecule called ferroportin, which otherwise helps to translocate iron from these tissues into the plasma. It inhibits the actions of ferroportin, and also and thereby decreases the availability of iron that could be used for erythropoiesis. So coming to renal anemia, always the cause is not only EPO deficiency and iron deficiency. There is also this chronic blood loss because of frequent phlebotomy. When the child is on hemodialysis, there is also some hemodialysis related blood losses, and also GI losses secondary to gastritis. Uremia and oxidative stress again account for the inflammation and decreased erythrocyte survival. Nutritional deficiencies in addition to poor diet, and the presence of hyperparathyroidism and myelofibrosis, which makes the bone marrow very resistant to the actions of erythropoietin, and also some medications that we routinely use in children with CKD, and some drug toxicities can all contribute to this phenomenon of renal anemia. So how do you evaluate a child for renal anemia? The preliminary test that one should be doing is the hemoglobin, looking at the complete hemogram, which includes the RBC indices, a peripheral smear, an absolute retic count, also the B12 and the folate levels. Anemia in chronic kidney disease is a state of hypocellular or a hypocellular marrow, or sometimes a decreased retic count can be there. There is normocytic normochromic anemia, or there can be a mixed picture with microcytic hypochromic anemia due to the presence of iron deficiency. A transferrin saturation tells you how much of transferrin is available for utilizing, for capturing iron and utilizing it for erythropoiesis. Of importance is this formula where there is transferrin saturation is calculated by this formula of serum iron and total iron binding capacity. Total iron binding capacity being a negative acute phase reactant can sometimes, the state of inflammation can falsely elevate your TSAT levels and give you a wrong information about the true iron status. Serum ferritin is again one of the markers that guidelines use to inform you about the decision to use iron in these patients, but that is also an acute phase reactant and is increased in states of inflammation. But these are the markers that are recommended for anemia evaluation by the current guidelines, the KDOQI and the KDIGO guidelines. All these markers give us information about the peripheral iron availability and also the transferrin utility of these of iron. But what is more important that we now realize, and what is being incorporated into guidelines in the Western countries, are that we need to assess what is the iron availability or for erythropoiesis within the marrow, within the erythroblasts. That's where the markers like reticulocyte hemoglobin content, reticulocyte hemoglobin equivalent, or percentage hyperchromic RBCs are more likely to be useful in the future for an exact assessment of whether there is a true or a functional iron deficiency. So these markers are directly dependent on iron availability and also have a shorter half-life, unlike our serum transferrin, serum iron and your total iron binding capacity and your ferritin levels. one should be looking at how frequently one should one be looking at these parameters when you're dealing with a child with chronic kidney disease. Hemoglobin should be checked as frequently as the stage of kidney disease progresses. Especially, it should be frequently monitored in children on dialysis and more frequently when the child is on hemodialysis. A patient who is who has anemia and also receiving erythropoietin stimulating agents or erythropoietin, there should be monthly monitoring of hemoglobin. And for a child on PD who is not on erythropoietin stimulating agents, the monitoring can be once every 3 months. We also should be looking at the transferrin saturation level and the serum ferritin level at least once every 3 months while the child is on erythropoietin therapy. The target mean hemoglobin levels are given here according to the KDIGO guidelines. The cutoffs for prescribing iron therapy and in children is a transferrin saturation of less than 20% and a ferritin of less than 100%, 100 nanograms per ml. For patients who are not on iron or ESA therapy, oral iron can be prescribed. And for patients, all patients on dialysis, except the ones on hemodialysis, should be receiving oral iron. Patients who are on hemodialysis and on erythropoietin therapy would require IV iron because of their increased requirement of iron and also the increased blood loss. The cornerstone of therapy for renal anemia is erythropoietin stimulating agents and either oral or IV iron. On this table here, you can see that there are many formulations of erythropoietin that is available. The erythropoietin alpha and the beta can be given in 1 to 3 times a weekly dose. The half-life of these agents can be increased by the second generation molecules for the darbepoetin alpha, which can be given in a dose of 0.45 to 0.75 microgram per kilogram. The epoetin alpha and beta can be given either subcutaneous or IV, while your darbepoetin can be given subcutaneous. With the darbepoetin formulation, the frequency can be reduced to 1 per week or once in every 2 weeks, depending on the severity and the rate of correction of anemia that you need. There are also long-acting molecules which are pegylated or have an additional polysaccharide chain to them, and these can be dosed once every month. Younger children compared to older children and adults require a higher weight-based EPO dose. The dose can even go up to higher from 275 to 350 units per kilogram for infants and can be in the range of 200 to 250 units per kilogram per week for older children. The goal for therapy should be no more than an increase of 1 to 2 grams per month with erythropoietin therapy. So that should be your target levels. While supplementing iron, oral iron at a dose of elemental iron at a dose of 2 to 3 milligrams and up to 6 milligrams per kg per day can be given in children. And the two commonly used IV iron preparations are the iron sucrose and the ferric carboxymaltose. The iron sucrose is a short-acting molecule and it's also has a higher molecular weight. It also has a longer, the relative stability is low compared to the ferric carboxymaltose, and there is a higher risk of reactions with iron sucrose. The frequency of administration is also quite more with iron sucrose. So more and more we are tending to use these ferric carboxymaltose, which is a less reactive and a highly stable component with less molecular weight. And also a higher dose can be given to these patients at a single administration. The dose for ferric carboxymaltose is around 15 milligrams per kg per dose as for 2 doses separated over a period of a week, where the maximum dose is 750 milligrams, or 15 to 20 milligram per kg per dose is a single dose where the maximum dose can be 1 gram. A mention about the emerging therapies for treatment of renal anemia. You might remember that the HIF molecule needs to be stabilized by without hydroxylation. So when it's hydroxylated, it's destroyed. When the HIF molecule hydroxylation is inhibited, it stabilizes the molecule and increases erythropoietin secretion. So this has been used, and a drug called HIF prolyl hydroxylase inhibitors are being approved in adults and have been recently introduced for clinical use. These can be orally administered in a thrice weekly dose, and they work much better in non-dialysis CKD patients, and we'll be using these in children in the days to come. Moving on to yet another very important complication, and which has a huge impact on the growth and morbidity status of our patients is the mineral bone disease. It is formed by a complex interplay of hormones, of at least 3 hormones, which is the 1,25-hydroxy vitamin D, the parathyroid hormone, and the fibroblast growth factor. 1,25-hydroxy vitamin D, as I previously mentioned, is secreted by the proximal tubule cells after 1-alpha hydroxylation. Low calcium and phosphate is a stimulus, and this enzyme and this hormone acts on the intestine, bone, and kidney to increase the levels of serum calcium and serum phosphate. There is increased intestinal absorption. There is increased bone. There is increased excretion from the bone, and also a decreased or an increased absorption of calcium from the kidneys. It also modulates PTH secretion through the vitamin D receptor on the parathyroid gland. A deficiency of 1,25-hydroxy vitamin D would increase the parathyroid secretion. The net effect of this hormone is the increase in calcium and serum phosphate. Parathyroid hormone, on the other hand, is secreted by the parathyroid gland. It is stimulated by both hypocalcemia and the low 1,25-hydroxy vitamin D. The calcium is being a potent stimulus. The gland has the calcium sensing receptor and the vitamin D receptor on the parathyroid gland, wherein a low serum calcium and low vitamin D would activate these receptors and produce an increase in PTH, which will increase the serum calcium but decrease the phosphate by increasing its excretion via the kidneys and also decreasing its absorption in the intestine. Fibroblast growth factor 23 is a new, or a rather recently recognized molecule. It belongs to a group of molecules called the phosphatonins, which are secreted by the osteocytes and to an extent the osteoblasts, and it acts through a co-receptor called the Clotho, which is expressed on tissues like the intestine, the parathyroid gland, and the kidneys. This FGF23 facilitates phosphaturia via the sodium phosphate transporter and also decreased intestinal phosphate absorption. And it also inhibits the 1-alpha hydroxylase enzyme, and it increases the 24-25 hydroxylase, which goes on to degrade 1,25 hydroxy vitamin D. So the net effect of FGF23 actions, it lowers the serum phosphate and also decreases the levels of 1,25 hydroxy vitamin D, thereby also decreasing the calcium levels. So this complex interplay is thought to be behind the mineral bone disease. Traditionally, it was thought to be that the first inciting factor for the onset of bone disease in low GFR status is the retention of phosphate due to decreased excretion by the kidneys, and that inhibits 1,25 hydroxy vitamin D and thereby also decreases serum calcium, which in turn increases the PTH level, setting off the consequences of secondary hyperparathyroidism. But more recently, with recognition of the actions of FGF23, we realized that the FGF23 molecule is increased in the state of CKD, and that decreases, keeps the phosphate level normal till a late stage of CKD, but it decreases the 1,25 hydroxy vitamin D levels and thereby increases the PTH and sets off this syndrome of secondary hyperparathyroidism. The MBD is defined by the presence of any of these 3 parameters, which is defined, which is laboratory parameters, bone abnormalities, and vascular calcification. The biochemical abnormalities could be in calcium, phosphorus, the intact PTH, or the vitamin D metabolism. In CKD, there is either a low or normal calcium levels and a high phosphate level, a high PTH level, which is secondary hyperparathyroidism, with or without vitamin D deficiency. Tertiary hyperparathyroidism happens when there is unchecked proliferation of the parathyroid cells because of constant activation, and then they become autonomous and secrete, either form an adenoma or a hyperplasia and secrete autonomously PTH hormone. There's also this disease called adynamic bone disease, which is a state of hypercalcemia and suppressed PTH levels where the bone turnover is very, very low. Also bone abnormalities, which are diagnosed by doing a bone biopsy and also by certain bone biochemical markers like your alkaline phosphatase, gives us information about the bone turnover, the mineralization, and the osteoid volume. You could either have a high or low turnover bone disease, a high being something like the secondary hyperparathyroidism and low turnover being the adynamic bone disease. CKD also results in prolonged CKD, especially also results in extraskeletal calcification, which predominantly occurs in the vascular structures. And also when it's very severe, it can also have calcification in the soft tissues, which can be diagnosed by an X-ray or a CT scan. An overview of the mineral bone disease management. It starts with having enough calcium in your body and also supplementing enough native vitamin D. And also you might be looking at dietary phosphate restriction, usage of phosphate binders, which could be either calcium or non-calcium based phosphate binders. With advanced hypoparathyroidism, you might be wanting to use active vitamin D analogs and agents called calcimimetics, and also dialysis and parathyroidectomy. A dialysis to control phosphate levels, and also parathyroidectomy when you reach the stage of tertiary hypoparathyroidism. As the CKD3 progresses, the institution of these measures will be needed in a staged manner. As early as CKD stage 3, you might consider dietary phosphate restriction and calcium supplements or phosphate binders. The intact PTH values are slightly higher for CKD, which are the normal values for CKD, because uremia gives a state of PTH resistance. And for normal actions of PTH on the bone, you need a higher level of PTH for its actions. So the normal levels of PTH in CKD could be higher than what is it for the general population. And before instituting all of these measures, kindly you should ensure that the vitamin D status of the child is corrected for, and also other parameters like the acidosis is treated for. As you progress through the stages of CKD, you might be using active vitamin D analogs like calcitriol, which is one of the most commonly used active vitamin D molecule. And as you move along, you might be wanting to use calcimimetics and also institute dialysis in CKD stage 5D for which would have a better control on phosphate. Moving on to a bit about the calcium-based and non-calcium-based phosphate binders, there are plenty of molecules like the calcium carbonate, calcium acetate, and calcium citrate. Earlier, this use of aluminium hydroxide was propagated for an acute but an effective control of phosphate that is no longer used, and this use is now not recommended. The other calcium agents, I've given the elemental calcium and the dosages here. In pediatrics, the calcium balance of the child is usually is in a state of a negative balance, and we need a positive calcium balance for better bone growth and better bone strength. So we preferentially use calcium-based phosphate binders, but in some conditions where there is a higher calcium level and also a very uncontrolled phosphate, despite using adequate doses of calcium binders, one might need to use non-calcium-based phosphate binders. The molecules that are commonly used are the sevelamer hydrochloride and the lanthanum carbonate. Sevelamer hydrochloride can be used at doses of 400 or 800 milligrams TDS based on the amount of phosphate, serum phosphate, and lanthanum carbonate also can be used at a 500 milligram TDS dose. These tablets are quite bigger and they are not very easy to administer, and the predominant agents still used are the calcium-based phosphate binders. Not only does CKD MBD alone is not the only factor that affects growth. There are multiple factors that would impact growth, and for enabling optimal growth, it is very imperative that we address all of these issues, ensuring adequate caloric intake with a high energy and sometimes a controlled protein, especially in the later stages of uremia, a low phosphate and a low potassium whenever necessary, and also using assisted feeding methods like gastrostomy, NG tube feeds, and sometimes using a TPN or intradialytic parenteral nutrition might be necessary to ensure adequate caloric intake. Correction of acidosis, anemia. Sometimes, despite correction of all the metabolic abnormalities, there is some irreversible bony deformities which will decrease the linear stature of the child, and that might have to be looked into. And when all these parameters are corrected, and only when all these parameters are corrected, one should look at whether the child needs growth hormone replacement, because CKD is also a stage of growth hormone resistance. Moving on to perhaps a least discussed, but one of the most important complications of CKD, especially a prolonged uremic state, is the presence of cardiovascular disease. This remains the leading cause of death, especially for children on dialysis and advanced stages of CKD. The risk factors for having cardiovascular disease are hypertension, anemia, fluid overload, malnutrition, hyperparathyroidism, and prolonged time on dialysis. All of these together attribute an additional risk for having a cardiovascular disease. Cardiovascular disease in children with chronic kidney disease happens because of an increased preload, which could be because of the increased fluid overload status and also increased renin-angiotensin system activation. And also there is an increased afterload, which is because of the decreased arterial compliance, which could be because of the mineral bone disorder and the calcium balance, which produces vascular calcification and decreased arterial compliance and hypertension. Both of these produce an increased cardiac output status, which chronically results in increased left ventricular mass. These mechanics of the left ventricular dysfunction is quite different in CKD in that there is a lot of not only concentric LVH, but there is also eccentric LVH, and it causes something called a maladaptive cardiomyopathy and results in all the other complications of cardiovascular disease that one would see, like hypertension, cardiac arrhythmias, diastolic, and also to an extent systolic dysfunction. And also, especially in younger infants, sudden death could be because of cardiovascular disease. So how do you assess the cardiovascular profile in children? The often performed tests are the electrocardiogram, which could identify left ventricular hypertrophy, and also the echocardiogram, which is done to assess the left ventricular mass, presence of any cardiomyopathy, also to assess the ejection fraction and the ventricular function. The other but less used tests and often used in research purposes are the carotid internal medial thickness, which would be high, and increased coronary artery calcification, which would indicate an accelerated atherosclerosis, especially in a child. Flow-mediated dilatation in the brachial artery and other cardiac biomarkers are now recently being recognized as beneficial in evaluation of cardiovascular disease in children. Again, control of or a better cardiovascular profile can be got by control of the risk factors that I just mentioned, and all of these together should be attempted, and decreasing the time on dialysis, ensuring that the child gets a kidney replacement therapy, an appropriate kidney replacement therapy like transplant is very, very essential to limit the cardiovascular complications. One of the important contributors to cardiovascular disease is hypertension. And as I just discussed, there are many reasons for this hypertension, which could be because of the activation of renin-angiotensin system, because of the reduced nephron mass, and also oliguria and sodium retention, which happens in renal failure. These together can increase the fluid overload status, and also the increased peripheral resistance due to increased vessel stiffness, all will increase the risk of hypertension in these children. Additionally, drugs like steroids, increased erythropoietin, high-dose erythropoietin, and drugs like cyclosporin increase your blood pressure risk. The load of hypertension or the in children with CKD is quite high, as to close to almost 50% of children have hypertension, and it's more in glomerular CKD compared to non-glomerular CKD, where there is less of fluid retention in non-glomerular CKD. Having hypertension is definitely associated with the increased progression of chronic kidney disease, having increased premature atherosclerosis. It is advisable that we reduce the blood pressure to less than 50th centile in children with CKD to decrease the cardiovascular risk. Monitoring depends on it's based on the risk of organ damage. With the increased or severe hypertension or uncontrolled hypertension, the monitoring should be done at least every 3 to 6 monthly period. And not only clinic BP might be enough. With a more severe hypertension and more risk of organ damage, one should also look at doing ambulatory blood pressure and also home BP, institute home BP monitoring into your treatment plan. The cornerstone, the treatment of hypertension should essentially start at a very early stage with non-pharmacological measures like low salt diet and ensuring appropriate dry weight in dialysis and using less dialysate sodium whenever possible. The cornerstone of drug treatment in a patient with chronic kidney disease is the AC inhibitors or angiotensin receptor blockers. Although they carry a risk of hyperkalemia with decrease in GFR, one should also preferentially use diuretics to decrease the risk of hyperkalemia and limit potassium in the diet, so that these agents can be used appropriately and in a good dose. Those in combination with diuretics remain the cornerstone of therapy for treatment of hypertension because they directly address the mechanisms of fluid retention and angiotensin and the RAS activation. The other add-on drugs could be long-acting beta blockers, calcium channel blockers, other agents like vasodilators like hydrolysine, and also drugs like minoxidil. Moving on to another important complication, which is metabolic acidosis. As I said earlier, the kidney also has an important function of producing net acid excretion. All of us have a net acid load in our body, and to maintain tightly the tissue pH, this extra acid load has to be excreted, and kidney is the primary organ for excreting this load. Younger children produce as much as 3 milliequivalents per kilogram per day of acid, while older children can produce somewhere between 1 milliequivalents per kilogram per day. And chronic kidney disease, because of parenchymal damage, there is less bicarbonate synthesis and low ammonium excretion. Some disorders of the kidney can also additionally increase the urinary loss of bicarbonate. Bone being a buffer in severe acidosis, bone gets affected in the stage of severe acidosis because the alkali buffers, the alkali comes out of the bone to neutralize the acid state. In early CKD, there is a normal anion gap metabolic acidosis, and as the CKD stage progresses, this acidosis slowly turns into a high anion metabolic acidosis. The severity of acidosis can be defined as mild to moderate in chronic kidney disease, which is usually in the range between 12 to 22. It is not as severe as you would look at, as you would encounter in a renal tubular acidosis, but it's still, this would cause significant morbidity for the patients. The consequences of bone disease are of metabolic acidosis are exacerbation of bone disease, increased progression of CKD, accelerated inflammation and poor cardiovascular profile, and abnormal endocrine function like thyroid function, and also abnormal accumulation of beta-2 microglobulin. One should treat this metabolic acidosis by oral alkali therapy with either a sodium bicarbonate salt or a sodium citrate salt. Guidelines recommend maintaining serum bicarbonate at more than 22 milliequivalents per liter. You should also, because these are sodium salts, they also increase the risk of fluid overload. So balance the risk of that and hypertension with liberally using diuretics and salt restriction otherwise in the diet. Moving on to, and this is another complication that has a huge impact on mortality and morbidity in chronic kidney disease. The infection risk, it is only the second commonest cause of death in children. It is 3 to 5 times more in chronic kidney disease patient compared to the general population, and the risk increases to 8 times for children on dialysis. CKD state suppresses almost all sorts of immune function, both innate immunity and adaptive immunity. There is decreased neutrophil and phagocyte function, cytokine response. Both adaptive cellular and humoral immunity are all affected. Children with CKD are at increased risk of vaccine preventable disease because they produce reduced titers of antibody, and even those antibodies that are produced stay in the system for very short duration compared to children of without CKD, and many of them need booster doses, additional booster doses of vaccine and antibody level monitoring. Of importance is this hepatitis B vaccination, where the where the antibody titers might be very low. You might have to recheck them and double dose some of these patients to reach desirable antibody levels. Pneumococcal vaccines, varicella vaccine, and annual influenza vaccine, although even if it's not into the routine schedule, should be actively pursued, and these children should be vaccinated for these. By virtue of their etiology of chronic kidney disease, like caput, they can have higher risk of urinary tract infections in an abnormal bladder or an abnormal system. Uroprophylaxis, instituting CIC and anticholinergics might decrease this risk. Children on dialysis on a catheter, on a vascular catheter, are at higher risk of catheter-related bloodstream infections, and also children on PD can get PD peritonitis. Also, they are more likely to be exposed to transfusion-related and dialysis-related infections like chronic hepatitis B, C, and HIV infections. Although I said that these are the major complications, there are again multitude of complications like fluid and salt retention resulting in edema, and you might have to look at salt, fluid restriction, and also instituting dialysis and better dry weight on dialysis. With decreasing GFR, the risk of hyperkalemia increases, and metabolic acidosis and the type of diet and having constipation, which decreases the gut excretion of potassium. All of this can increase your risk of hyperkalemia. So a strict, in case of hyperkalemia, you should look at the diet. If you can restrict some potassium in the diet, use of phosphate binders, control of acidosis, and also control of constipation might be necessary. Malnutrition and neurocognitive delay happen due to a multitude of factors that happens with CKD, which is because of the inflammation, the anorexia, the dysgeusia, and also dialysis loss of protein can result in malnutrition. And also, there's again a complex interplay can result in neurocognitive delay. The bleeding tendency could be there because of uremic platelet dysfunction. Gastrointestinal complications like gastritis, decreased GI motility, and having a reflux disease and constipation again can be there. These could be symptomatically managed most of the times by using proton pump inhibitors or H2 blockers and also modified feeding methods. Having a low GFR status increases the risk of drug toxicity, not only for drugs that are nephrotoxic, but all the drugs that are renally cleared can also, with those drugs, you can have increased non-renal adverse events, and those should be carefully looked into. You should use alternative agents when possible, and also use renal dosing of drugs. Avoid concomitant administration of nephrotoxic medications to further, also these patients are increased risk of acute kidney injury because of the diminished nephron mass that they have. And every episode of AKI sort of pushes them into a further stage of CKD quite quickly than the natural progression for that corresponding basic disease. So to summarize, there are many complications, not one, not two, but many complications of chronic kidney disease, and they can start as early as CKD stage 3. Many of them are due to the loss of endocrine and exocrine functions of the kidney, and also because of advanced azotemia. Renal anemia, acidosis, and mineral bone disease cause significant morbidity, and they should be detected early, appropriately treated with specific therapies. Cardiovascular disease, again, is a major cause of mortality and which needs control of all the risk factors. And there is CKD children are also at an increased rate or risk of infections, and you need to address these disease-specific risk factors like catheter infections and UTIs. Thank you.
So we had a very extensive discussion on the complications. I think we'll move on to the case discussion presentation by Dr. Hamsa Reddy, and we'll take the question answers at the end of that case presentation. Please add your questions on the QA box so that they can be taken up at the end of the session. Hamsa Reddy, please come.
Thank you, ma'am. Good evening, everyone. I would be sharing my screen and we'll discuss a case about complications of CKD. At the outset, while I'm sharing my screen, I thank the organizers for organizing the NEfPRO. Definitely, it is of much help for all the postgraduates, and also Sukanya ma'am for giving such a nice review on such a vast topic. So, is my screen visible?
Yes.
It's visible,
Okay.
yeah.
I'm going to take you through with very less time. It's not. Okay, I'm going to discuss a case. Here's an 11-year-old girl, Miss S, was brought with complaints of noticing bony deformities of bilateral lower limbs since the last 3 years. She's shortest in her class, and mother also gives history of waking up twice in the night to pass urine, and also she drinks lot of water, around 3 to 4 liters per day. And there's no history suggestive of any recurrent urinary tract infections in the past. And mother also denies any history of urinary incontinence or constipation. Currently, this girl is studying in 5th standard with fairly good scholastic performance. On examination, child weighs around 20 kgs. She's less than her third centile. Height is 120 centimeters, which also is less than her third centile. And her BMI is around 13.9 kg per meter square. She's hemodynamically stable with heart rate of 96, respiratory rate of 16, and BPs of 104/70 mmHg, which falls between 50th to 90th centile. Child has no dysmorphic features. She has mild pallor, but on examination, as you can see on the picture, she has bilateral knock knees. And on a systemic examination is normal. So we went ahead with the investigations. Here you can see a child who's brought with complaints of not growing adequately with some significant bony deformities. And on clinical examination, you see that the child is not hypertensive. She has some pallor and knock knees. And then on investigations, you see like as there was pallor, hemoglobin is 10.2 grams per deciliter, which is low, and her BUN is 29 milligram per deciliter, and serum creatinine is 2.2 milligram per deciliter, which corresponds to an EGFR of 22.5 ml per meter square per minute. As I think you have all been told that we calculate EGFR using modified Schwartz formula. And she has no hyperkalemia, potassium is 4.5, and there's no other dyselectrolytemia. She has acidosis of bicarb with bicarbonate of 14.5 milliequivalents per liter. The normal is around 22, so it is also low. Her serum calcium is 8.4 milligram per deciliter, which is low. Her serum phosphorus is 4 milligram per deciliter, which is normal, and she has a raised alkaline phosphatase. And her urine albumin showed 1 plus protein with no significant RBCs or WBCs in the urine. And we went ahead with doing her ultrasound KUB. Ultrasound KUB showed small kidneys of 5.2 and 5.6 centimeters with complete loss of CND. As you can see here in the image, this is the kidney. Usually the kidney's echo texture should be as that of the liver. As you can see here, it is very hyperdense and it is very small in size, and there is no differentiation between cortex and the medulla. So there are the z-scores of the kidney sizes are less than -2, so they're very small kidneys, and the urinary bladder is of normal wall thickness without any significant post-void residue. Her serum, other investigations, because she has anemia, we went ahead and did serum ferritin and transferrin saturation, as Dr. Sukanya discussed. Her serum ferritin is 56 nanogram per ml and transferrin saturation is 35.5%, which are both low. And the serum vitamin D is 25 nanogram per ml, which is of insufficiency, and serum PTH is high, 654 picograms per ml. So the diagnosis is CKD stage 4D, CKD stage 4, because the EGFR is around 22. Under basic disease is bilateral hypodysplastic kidneys, because as we saw, she has very small kidneys with loss of CMD. Under comorbidities currently are CKD MBD, that is mineral bone disease, iron deficiency anemia because the transferrin saturation and serum ferritin were low, and metabolic acidosis because her bicarbonate, as we saw, was 14 milliequivalents per liter. So I'll go ahead and discuss each complication and see how we managed her. So CKD MBD, as discussed, there are 3 components where there are biochemical abnormalities, where skeletal manifestations and extraskeletal manifestations. So she definitely had biochemical abnormalities with hypocalcemia and with elevated alkaline phosphatase and hyperparathyroidism. She also had skeletal manifestations with bilateral genu-valgum, as we saw. And how do we manage this child? As KDIGO 2017 update on CKD MBD guidelines say, if the patient has intact PTH which has progressively rising and is persistently above the upper limit of the normal, you have to evaluate for the modifiable risk factors like hyperphosphatemia, hypocalcemia, high phosphate intake, and vitamin D insufficiency. And in children, vitamin D analogs and calcitriol may be considered to maintain serum calcium levels in the age appropriate normal range. Though it is not of a significant, though there is no significant, it's not a significant recommendation, but this is what we usually follow. So now looking at her issues, what does this child have? She has hypocalcemia. So we started her on oral calcium supplementations at 75 to 100 milligram per kg per day. And we titrate the dose to maintain the serum calciums within the normal range. We don't want hypercalcemia, as we already discussed. Then the child has secondary hyperparathyroidism, and we know that she has some risk factors which could cause high secondary hyperparathyroidism. So we correct hypocalcemia, hyperphosphatemia, and vitamin D deficiency, and start the child on calcitriol and vitamin D analogs after correcting all these hypocalcemia, hyperphosphatemia, and vitamin D deficiency. So this child had hypocalcemia and vitamin D insufficiency. She was started on calcium carbonate 500 mg 3 times a day, to be taken 1 to 2 hours of before food. When we give calcium as a supplement, we have to give it before food for better absorption. When you're giving calcium as a phosphate binder, it is most often given with food to bind the phosphate in the food. So she was started on calcium carbonate at 75 mg per kg per day, and she was also started on capsule calcitriol, that is the active vitamin D form of 0.25 micrograms on alternate days. Going on to the next complication, this child we noticed anemia in CKD. So we diagnose in anemia in children with CKD if the hemoglobin concentration is is as per the age norms. In this child who was less than around 5 to 12 years, her cutoff hemoglobin is around 11.5 grams per deciliter, and as we remember, her hemoglobin was 10.4. So what do we do? KDIGO anemia guidelines state that with children with CKD and have anemia with who are not on iron or ESA therapy, we have to start them on oral iron at when the TSAT is less than 20% and ferritin is less than 100 nanogram per ml. So this girl was started on tablet ferrous sulfate, which contains 65 mg of elemental iron, to be taken on empty stomach at 6 mg per kg per day. As we know, the starting dose is around 2 to 3 mg per kg per day, and we go up to 6 mg per kg per day. And we, since this girl has iron deficiency, she was started at 6 mg per kg per day. And whenever we are prescribing iron, this has to be told clearly to the patient and the attenders that it has not to be taken with the calcium supplements, because it causes, there will be less absorption of the iron as well as calcium when they are taken together. And the patient has been counseled about the iron rich diet. Then the next complication, as we go ahead, the child had metabolic acidosis. So KDOQI guidelines recommend to start sodium bicarbonate to maintain at a level at or above 22 milliequivalents per liter by supplementing oral bicarbonate. So she was started on oral bicarbonate supplements at 1.5 to 2 milliequivalent per kg per day in 3 divided doses. Bicarb is available as oral, as tablet as well as syrup formulation. So after 1 month, the child comes to follow up. So as we from Dr. Sukanya's talk, we know that all children with CKD has to be monitored very regularly to see whether the therapy we have started has been showing any changes, and also see for the progression of the disease. So after 1 month at OPD follow-up, her hemoglobin is showing significant improvement. From 10.2 it has increased to 10.8. Her serum creatinine is almost the same, 2.2 milligram per deciliter, and she has no dyselectrolytemia as of now. Her bicarbonate has improved from 14.5 to 20 milliequivalents per liter. Her serum calcium has improved to 9.6. Her phosphorus is 4.2, and her alkaline phosphatase has reduced because we have supplemented her with calcium and also started treating her secondary hyperparathyroidism. Now the child was continued on the same prescription, and the child was advised to follow up once in 2 to 3 months. CKD stage 4 needs once in 3 months follow up. So child has been advised to follow up once in 3 months. Now, after 1 year, the child has been on regular follow-up, but the mother, she's been complaining that her appetite has reduced for the last 2 months. There's also a history of easy fatigability. Child is not being able to manage herself in the school. She comes back home early, and there's no history of any altered sleep behavior, nausea, or vomiting. These are the symptoms. We have asked to look for any uremic symptoms if the child has any. Now, currently the weight is around 20 kgs. Her height is 121 centimeter. There is no significant height or weight gain during the last 1 year. And her BP now we see is around 122 by 80 mmHg, which is more than her 95th centile, which qualifies as hypertension. The child persists to have bilateral knock knees, and the child is also having a pallor on clinical examination. So after we know this investigations at baseline and after 1 month. Now at this follow-up, the child's hemoglobin is around 8.6 gram per deciliter. So there's a significant decrease in the hemoglobin with serum, and as well as the serum creatinine has increased from 2.2 to 2.8. There's no dyselectrolytemia as of now. Her bicarb, there is no metabolic acidosis. Her CKD MBD looks much better with calcium of 9.4, phosphorus of 4.2, and alkaline phosphatase of 440. Her serum vitamin D levels are 34, which is sufficient, and her PTH has suppressed appropriately, and now her PTH is around 190 picograms per ml. Her serum ferritin is 368 nanogram per ml, and serum transferrin saturation is 35%, saying that she is iron replete now, but then with the adequate iron stores, the child is having anemia. So now currently her issues are basically she has hypertension to begin with her BP of 122 by 80 millimeters of mercury, and the child also has currently now anemia, which is iron replete. So let us see how we went ahead and treated this child. Now hypertension in CKD. Now we know the pathophysiology. The KDIGO 2021 BP guidelines say that it's in children with CKD, we have to do ABPM, and mean arterial pressure should be lower to less than 50th percentile for age, sex, and height. So what is the target BP in these children is to bring down the BP to the 50th percentile for their age, sex, and the height. Now, how do we treat them? Use ACE inhibitors or ARBs as a first line therapy for high BP in children with CKD, as it was discussed. And having said that, though ACE inhibitors and ARBs are the first line therapy, they carry the risk of hyperkalemia, and so the potassium has to be monitored, and also they carry the risk of reduced GFR. So they need to be monitored once we start them on ACE inhibitors or ARBs. She was started on tab enalapril at 2.5 mg twice per day at around 0.3 mg per kg per day, and she was advised to review after 1 week in OPD to monitor her for her serum creatinine and serum potassium, because we know that they increase potassium and also reduce the GFR. Now, what happens to the anemia in CKD? We know that child has anemia despite normal iron status. Now, the child has been initiated on injection EPO at the dose of 2000 units per week. This is around 1000 units per kg per week for her. So the starting dose is around 75 to 100 units per kg per week, and we can go up to the dose titrate up till 200 units per kg per week in this age group. Now, the oral iron, though she is iron replete, her iron has been continued at 3 mg per kg per day, and her ferrous sulfate tablet has been given at has been reduced to 1 on empty stomach, since she is iron replete. Now, what is the target hemoglobin which has to be maintained? Which is maintained between around 11 to 12 grams per deciliter. Now, so what did we learn? Most of the complications in CKD are usually seen between above stage 3 and above. Not that they're not seen below stage 3, but then most of them physically can be seen, or they start having symptoms after stage 3 and above, and these children have to be monitored at regular intervals, and then the identification and treatment of these complications improve their quality of life and also retard their progression of CKD. Thank you.
Thank you very much, Elsa, for this very clear presentation illustrating all that was discussed earlier on the management. I think we can now move on to the question answers. I think there is only one question that I can see. I'll just read it out, and maybe Sukanya could answer it. What could be the cause of high phosphates post-parathyroidectomy in a child? Calcium, vitamin D, I don't know what is BUSC, acceptable. And I believe it's due to diet, but parents deny. He's on calcium carbonate now and calcidiol. But would one add sevelamer or lanthanum if it remains above 3? I presume this is millimoles, and that would be about 9 milligrams per liter. PTH is 5.5 and alkaline phosphatase 155. So, would you like to address this?
Yeah. I'm not sure about the stage of the CKD here, but a high phosphate levels, despite a normal calcium carbonate, despite having a parathyroidectomy, the calcium and calcium status seems to be fine. So the control of phosphate in a child with CKD starts from restricting phosphate in the diet. And when that is also done, you should look at adding calcium-based phosphate binders. And when that is not enough, one should look at adding non-calcium based phosphate binders, like mentioned, like sevelamer and lanthanum, and then later dialysis, depending on the stage of CKD. So when you're looking at the diet, it's very important to know what are the richest sources of phosphate in the diet. Your phosphate additives that are very commonly used in many of the food substances, that should be carefully asked for with the parents, like cola flavored drinks, all the readily made processed foods all have high inorganic phosphate, which has a very high bioavailability. So that should be reduced in the diet, and that can cause a significant impact on the serum phosphate levels. And also sometimes restricting phosphate might be tricky in the diet, because of the it would also decrease the protein in the diet. Many of these sources of phosphate are also rich in protein, so one should carefully look at the diet to see that there is enough protein, but there is less phosphate. Some good sources of phosphate, less protein are eggs, and eggs and cereals can be used. Looking at the coming to the management of phosphate by using calcium based binders. Often in clinical practice, when you give calcium supplements, these calcium supplements, if they need to have a phosphate binding effect, need to be given along with or just after food. So we do recommend, when it's calcium supplements are given for treatment of hypocalcemia, it's better taken in an empty stomach. But if you want an additional calcium phosphate binding effect, you might add a couple more tablets along with the diet to have a better phosphate binding effect. So one could look at that. Also, sometimes having an active vitamin D analog can increase your phosphate despite helping your calcium. So one might have to revisit the dose of an active vitamin D analog. All said and done, if the calcium phosphate product is very high and you've maximized your use of calcium based phosphate binders, one should look at using Sevelamer, which is more commonly used between the non-calcium based phosphate binders. And ultimately, if the child is in CKD stage 5, and if you're starting dialysis, an adequate dialysis dose or a thrice weekly dialysis would be sufficient to additionally control the phosphate.
Thank you, Sukanya. I think is there any other? Yeah. What is the maximum dose of erythropoietin which can be given per week? Absolute value, not the per kg dose. Hamza, would you like to take this question?
Yes, ma'am. Okay, so we start the EPO at a lower dose, around 100 units per kg per week, and we increase the dose by 25% every week to see the response. To say, like, by literature, we can go up to 40,000 units is the absolute dose which is given even in the adults. But then I have not seen, but the literature, like when you look at the leaflets, they say up to 40,000. But then what I've seen is up to 10,000 units per week is what they give, which is also available. But we don't give the EPO, we don't give, like, keep increasing the dose more than 25%. If you're in 4 weeks, if you started increasing the dose of EPO by more than 25% for 4 weeks, and there is no adequate response, then you have to look at the EPO resistance and then start working up for that, rather than looking at the absolute value and giving 10,000 units per week and you know that there is EPO resistance. So I think more than the absolute value, how you titrate up and see the response is what matters.
Fine. We have another question here. Sukanya, could you take it? Do we have to start on calcitriol on alternate days only?
Not necessarily. So calcitriol is an active vitamin D analog, and usually we start calcitriol for
Dr.
patients.
Sukanya, you're not audible. You'll have to step closer.
Yeah. So calcitriol is an active. Can you hear me now?
Yeah, we can hear. Just speak a little louder. Yeah, that's all.
So calcitriol is an active vitamin D analog, and it's usually started in a child with CKD when, despite adequate control of your calcium and native vitamin D status, when the PTH levels are very high, we institute calcitriol to sort of control the secondary hyperparathyroidism. This agent is better started in a dose of, say, a daily dose, but it's very important to understand that when this agent also has the ability to suppress your PTH too much and then result in hypercalcemia. So many of us do start with a daily dose, but the important thing is to monitor the PTH and the calcium levels. And once it is well controlled and it's in the range that you want to, you can step down to an alternative therapy rather than completely stopping it. So if you see in clinical practice, many of us would have started it in daily doses, but then stepped back to an alternate day dose. So that is one way of treating using these agents.
Hamza, is there any role of alpha calcidiol in CKD?
Okay, as per the guidelines, what they say is either you use like as we said, calcitriol or vitamin D analogs. As alpha calcidiol is a vitamin D analog, you could use alpha calcidiol, which is 1-hydroxy cholecalciferol. But having said that, most often we do use, I mean, we use calcitriol because it's a more active form of 1,25-dihydroxy vitamin D. So there's like, can you use it? Yes, you could use alpha calcidiol also in the management of CKD MBD.
Okay. So, Sukanya, there are two questions which I think I will combine and ask you to answer. When should we start iron and EPO simultaneously? That is one. And the second is, can EPO and HIF alpha inhibitors both be used in a patient?
Often, so when you're seeing a patient very early in the stage of CKD, like CKD stage 3, where only an iron supplementation might be enough. But often when you see patients crash land to us, they are already in CKD stage 5, their hemoglobin is very low. Some of them are even require transfusions. So in these patients, we do start erythropoietin and iron simultaneously. When you're so most likely we start iron and EPO simultaneously in advanced stages of CKD under continuous follow-up. So they can be started. And when on ESA therapy, they would need more of an IV iron to accommodate for the increased iron requirement at that stage. So that is to answer that question. And whether EPO and HIF, so HIF alpha inhibitors are sort of newer drugs that have come into the market, and they are predominantly now being used, although sparingly, in adults. So it's just now reached India, and many adult nephrologists would be using these HIF inhibitors. And they are all predominantly used in patients, and they're more beneficial, as I said in my talk, in non-dialysis dependent patients. So I'm not come across anybody using or the literature suggesting that we use them together. But HIF alpha inhibitors work better when you use it in non-dialysis CKD, and it's used and it's practically introduced as an agent, as an alternative to erythropoietin. So it sort of defeats the purpose if you're going to use both EPO and HIF inhibitors. I personally have not used HIF alpha inhibitors in any of my patients so far. So I think HIF alpha inhibitors would be better used in non-CKD, non-dialysis patients, and EPO will be reserved for patients on dialysis, but not together.
Hamsa, there's one question on the chat box. Is
Yes.
there any evidence for efficacy of megestrol and alpha keto analogs advocated by pharmacy representatives?
That's a question difficult to answer, but like as for evidence, there is no, I mean, as far as I know, there's no role of megestrol, or there is no randomized trials which have looked at megestrol or alpha keto analogs in pediatric CKD for the for any benefit. But I've seen multiple prescriptions, but I don't there's no solid evidence to start them as of now for the treatment of CKD, ma'am.
And I think we've come to one last question. Any age cutoff to start darbepoetin, Sukanya?
I'm not aware of any age cutoff for darbepoetin. When you want to decrease the frequency of erythropoietin administration, especially darbepoetin can be used for children who are not yet, who are on peritoneal dialysis, where the number of injections that they get might be slightly lesser when compared to patients on HT, where you have the opportunity to give it IV and reduce the number of injections. Or so that one, I'm not aware of any age cutoff per se.
There's one more question that's come up for thing. One is, what is the water intake, recommended water intake in CKD5? Hamsa, could you answer that? Daily water intake?
Yes, ma'am. So the daily water intake depends on multiple things. One depends most importantly on the urine output of the patient. If the patient is oliguric, you have to restrict the water. If the patient is, most of the pediatric CKD is, the most common cause of pediatric CKD is CACUT. So usually, because it is a tubulointerstitial problem, most of our pediatric CKDs would be non-oliguric. So if a child is non-oliguric, there is no need to strictly restrict their water intake. They can take the maintenance fluids or whatever they're taking. But if the child is oliguric, you would definitely restrict the fluids. How much to restrict is a question based on what is the child's weight and what is the intake of the child, and whether the child is on dialysis or not on dialysis. If the child is not on dialysis, if the child is oliguric, so there will be edema. So you would probably restrict them to their 50% of their maintenance fluids. And as I said, it is not a hard and fast rule. It is based on multiple factors, like, how much is the child passing, whether the child is responding to diuretics, is the child edematous, what is the hypertension, all those factors. So we should do we should be careful about, like, what water restriction based, rather than absolute value. It is mostly dependent on the condition of the child.
Very true. Sukanya, I think this is a follow-up statement of that parathyroid first question. The whoever's asked has put that this patient is on APD. So would you have any advice for the dialysis for this patient in view of high phosphates?
So when you're using peritoneal dialysis is a modality, and phosphate removal through peritoneal dialysis can be better managed by using modifying the prescription to better remove phosphate in the PD by the peritoneal dialysis. A longer duration of phosphate and adding more cycles and more volume of PD fluid to be put in each cycle. So all of these can influence phosphate clearance, and that's how the dialysis can be optimized, if that's what this delegate wanted. So on APD, you can increase the dwell volume, you can increase the number of cycles, which will total dialysis dose, and also keep a longer dwell, which will entail the phosphate removal. So phosphate removal needs a longer dwell time. So those are the things that can be used to additionally improve the phosphate clearance for this child.
So I think we've come to the end of our questions. So I thank all the panelists for the excellent talk and discussion, and all the attendees for the active interaction. So over to the organizers.
Thank you, ma'am. Thank you for the excellent moderation, and thank you, Dr. Hamsa and Dr. Sukanya, for the talks. I would request Sneha for starting with the post-test.
Yes,
Thank you, ma'am.
So we are launching our first pool. Is it visible?
Yes, it's
Yeah,
visible.
it's visible.
Okay. So 20 seconds more. Ten seconds more. Thank you. Moving to our next question. Fifteen seconds left. Thank you. Moving to our next question. Last 10 seconds. Thank you. Moving to our next question. Twenty seconds gone. Thank you. Moving to our next question. Another 20 seconds. Last 10 seconds. Thank you. Moving to our next question. Fifteen seconds more. Thank you. Moving to our next question. Fifteen seconds gone. Thank you. Moving to our next question. Another 20 seconds. Last 10 seconds. Thank you. Moving to our next question. Fifteen seconds more. Thank you. Moving to our next question and the last question. Ten seconds. Twenty seconds. 30 seconds. Thank you. No polls left. Thank you, sir. Thank you, ma'am.
Thank you, Sneha. And thank you, ma'am, Dr. Hamsa, Dr. Sukanya, for this excellent session. Thank you, panel delegates, for attending. We will meet again on Sunday at the same time. The topic of the talk on Sunday would be kidney replacement therapy for chronic kidney disease. So we look forward to another important session on this Sunday. So do remember to join us then. Thank you. Thank you, everyone.
Thank you so much, everyone. Thank you.